Good afternoon, and thank you for joining us for today's webinar, Assessing Cone Beam CT Imaging Trends. Before we begin, I would like to go over a few housekeeping items. Today's webinar will be recorded and available through our website and the RadSite YouTube channel. To minimize noise and distraction, all attendees' microphones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using your Q&A box. We will do our best to address all questions and comments at the end. I'll now turn the presentation over to our moderator, Mark Casner, RadSite's Chief Accreditation Officer. Thank you.
Thanks, Sandy, and thank you to all who are joining us today. We have three terrific presenters. I'm going to let them do their own introductions, and we'll start with David Georges.
Thank you, Mark. My name is David Georges. I'm the president of Koning Corporation, and we are the first FDA-cleared breast imaging device using cone beam technology. I've been with the company for over 11 years. I've been in the breast imaging industry for 40 years, and I'm finding my work with RadSite to be very fulfilling and also excellent for the accreditation side of cone beam breast CT. Thank you.
Thanks, David. Robert Chen.
Hi, thank you. Yeah, my name is Robert. I'm the owner and I operate Reveal Diagnostics and Reveal Surgical Guides. We're a third-party imaging laboratory facility, and we specialize in CBCT imaging. So doctors will send patients directly to us to have the imaging done. And we've got 7 facilities throughout Northern California and Portland, Oregon. We've been doing this for about the last 14 years.
Great, thanks, Robert. And last but not least, David Luick.
Hi, I'm David from Tungsten Medical. We specialize in-office cone beam CT, specifically for ear, nose, and throat physicians. We provide sales, service, all of the ancillary things that you might need, like physics testing, PACS, remote backup, even dosimetry badges. I've been in the market now for 18 years and been with Tungsten for 9. Happy to be here. Thanks for having us today.
Great. Thank you, David. And just a note to our audience, obviously we have 2 Davids here, so it may be a little confusing. If you have specific questions, if you could list either David Georges or David Luick, I think that will help at the end. So let's just jump right into cone beam CT imaging general trends. And Robert, maybe we'll start with you. What are you seeing in the dental? Dental's been around a long time, and maybe you can share some of the chronology of what's been going on.
Yeah, so in the earlier days of CBCT, we were seeing not a lot of use because just CT as a modality was not nearly as effective, right? So we were seeing the technology used for axial CT imaging very much in just like large orthognathic cases. When CBCT first emerged, it was a big deal, mostly in surgical and kind of expanding into other aspects of dentistry. But with prices coming down and footprint also being a big deal for in-office type clinic, footprints getting smaller, it's just become the adoption of CT has really skyrocketed, and it's becoming much more a standard of care now, very well accepted. And it's funny, we say the biggest contributor now to growth in the CBCT market is the breaking of panos. Because with the footprint and the size now, when people have their panos break, why not get a CT, right? Why not put one in there?
Okay. Thanks, Robert. And so David Luick, your group tends to specialize in ENT. Talk to us a little bit about the trends on the ENT side of things. That's more of a medical specialty, obviously, than dental.
Yeah, I mean, a similar experience to Robert in that, in the early days, the scanners are actually much more expensive than they are now. And now, I mean, they're affordable, I think, for nearly every ear, nose, and throat practice. Even the solo doc practices can justify having their own CT scanner in their office. The break-even point on a CT scanner is somewhere around 15 to maybe as many as 20 scans per month. And most solo practitioners are doing that many, which means medium and large groups, it's a no-brainer for them. But now, again, since the price point has come down, practices are putting them in their satellite offices to just, ensure that patients have access. So I've noticed that over the years, it's just becoming more of, as Robert said, it's standard of care. I think, in my estimation, maybe 40% or so of ENT practices have a CT scanner now. So still, there's a lot of room for growth. Um, but more and more practices are just identifying the need and uh, and getting one installed.
Great, thank you. And David Georgia, so you're kind of the newest on the block here. Perhaps you can tell us a little bit more about the breast CBCT and the trends there as you're in the very nascent stages of that.
Yes, we are, Mark. And actually, it's been a pleasure to be at the beginning of this journey of moving breast imaging to cone beam breast CT. There are many advantages. I think we're going to talk about those in a minute. But today, the existing breast imaging world is a series of mammograms, multi-view mammograms, and there's a lot of limitations in that current standard of care, and we were hoping that by introducing cone beam breast CT, we could improve on the exam, both for the radiologist as well as for the patient. And it looks like the industry is beginning to take notice. So we're very pleased to see what's happening at this early stage of launching cone beam breast CT into the mammography industry.
Thank you, David. Let's stay with you for a moment and talk a little bit about the regulatory environment. Again, you're kind of brand new to this. What, if any, regulatory hurdles are out there for you?
Well, we're in an industry that's approximately a little over 40 years old using congressional mammography, which is a two-dimensional image of the breast. And from a regulatory perspective, this was a brand new front for the regulations across the globe to be looking at a completely different technology for breast imaging. Now, we, of course, had to go through an FDA PMA rigorous trial in order for the FDA to consider breast CT, cone beam breast CT, suitable by comparison to today's mammographic environment, which we succeeded with flying colors in that regard, and we have since grown to over 20 countries with regulations. So I think as the regulators and the registration process continues to be introduced to the technology, we're seeing a very bullish outlook on cone beam breast CT from the registration and regulatory perspective.
Great, and I know we're going to do a little deeper dive here in a moment. So David Luick, talk a little bit about ENT, and again, at Reddit, you've talked about 40% of the practices having that. Any regulatory hurdles on the ENT side?
It really varies by state. Some states, the regulatory hurdles are minimal, as in um, anyone can push the button, anyone that's trained, that is, that can push the button. In other states, you may have to be a physician or a CT tech to push the button. That can be a little bit more onerous for a practice to adopt this new technology because the doctor is already, as I'm sure you can imagine, busy enough that they don't want to add one more thing. So that can be a little bit more challenging there. But in the states where the regulations are, you just have to fill out a form, advise the state that you're putting this technology in your office. We provide all of the training for the staff. It's much easier for those practices to adopt that technology.
Great. We're going to stay with you, David. We'll skip to the next slide. We'll talk about CBCT acquisition. And I actually want to start at the bottom here. Any special shielding that needs to go on if you put a cone beam CT in the physician's office?
So we do what we call a site survey for every installation. That means we measure the room that the scanner is going in. We measure the distance from ISO center to any of the adjacent areas or the operator. And then we calculate the planned utilization of the scanner itself. And most of the time, no additional shielding is needed. Now, if it's a very busy practice and they're doing a few hundred scans a month, it's possible that some additional wall shielding is needed. We usually provide some kind of solution for that. But then the radiation is monitored going forward. So we've got a couple bullet points here. So first is the shielding plan itself. And again, that calculates what shielding if any, is necessary. We always have an operator barrier at a minimum, of course, to protect the operator. And then we measure that radiation in two ways. We've got dosimeter badges that measure dose to the operator, and then we have a control badge that's somewhere in the office. And then we have annual physics testing that measures the actual output of the CT scanner each year, just to make sure that everything is, performing to specification.
Great. And David Georges, I'm going to slip back to you now to talk about breast in particular and the specific anatomical differences between mammography and cone beam CT.
Yeah, sure. Actually, with cone beam CT, we were capable of gathering all of the data of the entire breast in an uncompressed environment, which means that we're seeing it in a normal, natural presentation. And because it is CT as opposed to a two-dimensional acquisition, we are able to use the tools of whole body CT to interrogate the image, meaning that we can do co-registration in multiple planes, maximum intensity projection, and multiplanar reconstruction. So we took a page from the whole body CT book, applied it to cone beam breast CT, and we're ending up with a phenomenal product for the radiologist to be able to quickly interrogate if there in fact is a condition of the breast that needs further evaluation.
Great. Let's skip to the next slide, please, and talk about some imaging challenges. And Robert, let's start with you here. In terms, dental obviously has been around for quite a while. Let's talk a little bit about field of view and some of the issues that arise with that.
Yeah, I think with field of view, because CBCT and dentistry, we're going to see a lot of different use cases. I think the largest field of view tends to be orthodontics, right? So we're looking at a much larger area, the relationship of the jaws and just skeletal structure of the entire head, and sometimes even using that for measurements in a cephalometric analysis. So generally speaking, we need to get a much larger data capture. What we see is that, that is meaning that we are taking lower resolution images just by necessity. But I think for the purpose of orthodontics, that's typically fine because what we're assessing doesn't need super high resolution, right? We're not really assessing quality of bone, for example. It's more of just spatial relationships. If we have, for example, impacted canines, are they buccal or lingual? So it's really just, generally speaking, looking at a lot more just relational positioning, and that CBCT does an amazing job of that, and even at super low resolutions. Slightly related also, it means we can do much shorter scan times for orthodontics because we don't need that super high resolution, and that's nice, especially for kids, where well, A, we want to be mindful of the exposure for children, but B, getting them to sit still for a scan is always going to be quite a bit harder, right? So having a lower resolution scan allows us to use a quicker scan time, and we have just generally less motion. And then kind of in between, when we look at anything on the surgical side, anything on the surgical side, we're going to have a higher resolution because we are needing to assess for bone quality. And so we're going to limit down our collimate down our field of view, usually just to get the area of interest. And that lets us get a higher quality scan, and also just kind of limits us, for a lot of dentistry, we're trying to avoid imaging areas that we're not either trained in or comfortable with assessing. So we'll see that. And then probably the smallest field of view that we tend to see is in endodontics. So if we're trying to assess as small as canals within individual teeth, it becomes a lot more critical. We need a lot higher resolution to be able to do that. So typically we're going to get the smallest possible and the best imaging for those endos, and that's probably the most challenging use of CT. And just in the scope of all of the different machines that are out there, the very small and for endodontics tends to be much different, different type of machine, different quality.
Great. David Luick, talk to us a little bit about image quality and some of the changes that you've seen over the years.
Well, I always say you can't have a conversation about image quality without also having a conversation about dose. So I think that's really important to talk about hand in hand. And so the first question is, what is the intended use of the image? Because we have, a menu of different products that would suit the needs of different ENT physicians. So for example, if someone, like an allergist, for example, is just doing sinus-only scans, their image quality needs may not be as high as an otologist that needs to look at the detailed structures of the temporal bone. So we've seen some changes there, as it relates to what these scanners are capable of. But again, comparing cone beam CT to conventional CT, the image quality differences are stark, but the differences are, at what cost? And with a conventional CT scan, you might have 5 to 10 times as much dose to the patient. And sure, you're going to see the low contrast, soft tissue resolution that you might need to see in the brain, for example. But to look at images of the sinuses, a bone window high contrast image is going to suit most ENTs just fine. But I have seen over time, in the last almost 20 years now, the image quality has improved dramatically from the first iterations of cone beam CT that came out in the early 2000s to what we have today. And again, the price point has come down significantly. You get a very nice image in 10 to 20 seconds. And, the field of view is also going to be appropriate to what that physician needs to see. So either you're looking at something that's maybe, 12 centimeters tall, you'll get the bottom of the maxillary, top of the frontal, tip of the nose, the back of the sphenoid for, your typical ear, nose, and throat physician. Or you're going to get something with a smaller field of view, higher resolution, maybe a 60 millimeter by 60 millimeter field of view for just the temporal bone. So the image quality can vary, but it's by design and by intent of the end user.
Great. And David Georges, speak to us a little bit about the contrast between mammography, traditional mammography, and breast CBCT.
Sure. Well, we are, first of all, in the world of early stage breast cancer detection, providers of services are in the most highly regulated subset of human imaging through the Mammography Quality Standards Act. And that means that identifying the resolution to find these 2 to 3 millimeter stage 1 cancers is absolutely essential. And we're doing it in a body part which is completely made up of soft tissue. Of course, there's dense tissue and fatty tissue combined, but resolution is truly the name of the game. And in cone beam breast CT, we had to find a way to produce a 100 micron image. And that was to just stay even with what kind of imaging radiologists have come to expect from a mammogram. So the idea behind both maintaining a low level of dose, but a very, very high level of contrast and spatial resolution in the 100 micron environment was an absolute essential element for cone beam breast CT development. And obviously, because of our regulatory clearances, we've met that challenge and are doing a tremendous job of producing these high resolution images in 3 dimensions.
Great. Let's stay with you for a moment, David, and talk about this is kind of a 2-part question, I guess. One is the technologist or whoever is doing the imaging, and who's interpreting that? Is that a physician? Maybe you can speak a little bit about the folks that are involved in the actual image production.
Yeah, sure, of course. Obviously, the balancing, the three-legged stool balance here is you have a patient, you have an operator, and you have an interpreter. And we can clearly speak to the female patient population and the various sizes and what have you that cost us the need to change technique based on the size of the breast. The operator itself is a person, depending on the location and what the state regulations are. We are either going to use a CT technologist, a mammographic technologist, both of which are certified in the vast majority of states. And in many, many of the states now, because of the low output and the lack of need for positioning skills, and I might add to that, that positioning skills are extremely important in mammography because you're pulling the breast tissue into the receptor and then compressing the breast to hold it in place and to reduce the depth. None of this is needed in cone beam breast CT. The patient just lies comfortably on the table. The operator looks at a monitor on the wall that has a camera projecting the breast image. They've been taught to make sure the tail of the axilla, the nipples in profile, and the inframammary fold is able to be imaged. And then they take the expose button, which is managed by automatic exposure control by way of scout image. So there's very little left from a skill set to do the operator portion of operating a cone beam breast CT by comparison to the mammographic environment. The interpreter is obviously a radiologist, and a radiologist that has been trained in breast in breast imaging. However, if we look at the findings morphologically, because we are an X-ray emitting device, morphologically, the findings are going to mimic very much what they're accustomed to seeing in a mammogram, other than the fact they're now able to interrogate them in all dimensions as opposed to a two-dimensional environment. So when we look at that operator environment, sometimes we can use a state licensed general technologist to operate the machine. We can train them to do that in a couple of hours. And then from a radiologist perspective, we have a very comprehensive radiologist training course that we offer that is underwritten through Wake Forest Medical College for continuing education points for the radiologist. But the adoption rate from the interpreter has been excellent. And I think the learning curve, they don't feel is very onerous at all to go from mammography to cone beam breast CT.
Great. Robert, same question. So, dental cone beam CT has been around a long time. I'm sure, well, I'll speak from personal experience. When I have my x-rays done, it's the hygienist who's doing it. So talk to us a little bit about the same process. Who's taking the pictures? Who's interpreting the pictures?
Yeah, in the typical dental office, I would say there's, they're really no strangers to x-rays and radiation, right? So typically the assistants are trained to take the imaging. And so, yeah, whether that's just your regular course of small 2D films or taking a larger scan or an x-ray, like for the CBCT imaging now. So I think that is fairly common, well established across the country. Where we do see a little bit more of a gray area is within the interpretation of it. And so what we're seeing is the responsibility of the interpretation, at least here in the US, often lies with the clinician. So the dentist or the surgeon who's having the image. Now, I think there's no clear legal precedent in how much they are legally required to diagnose. So anything that is clearly within the scope of dentistry, yes, absolutely. But one of the challenges for CT that goes for an image that goes beyond just the dental area, to what extent is the clinician responsible for that? And that's kind of the gray area that we are still working on developing. So what does that mean is, a lot of times we work with very good radiologists who are going to assess every scan, help diagnose, and then also look for any incidental findings and just making sure that there's nothing in that image that we are not catching. And, in a lot of situations, that's very valuable from, A, from just a liability point of view, but B, just to be able to provide early detection for patients who maybe didn't know that they had some kind of other hidden pathology. So again, no clear legal precedent. Some clinicians send every single scan to the radiologist. Some learn how to do some of this assessment themselves. And some kind of just want to limit everything down and saying, hey, I'm just going to take small field of view imaging so that we're not having to have that conversation about interpretation outside of the dental area.
Thank you. And David Luick, don't want to let you off the hook. Same set of questions?
Yeah, that's interesting because, I think ENT is a little bit different in the sense that we encourage our ENT physician customers to do their own interpretations. And by and large, most of them do. I think maybe 95% of our ENT physician customers will do their own reads. I think if we're looking at the allergy market, perhaps an allergist may be sending out more of their reads than the typical ENT does. But we encourage most of our, like I said, our ENT physicians to do their own. So that means when the patient gets the scan, they're getting a preliminary read almost immediately. In some cases, it is quite immediate. It's within 30 seconds of the image being acquired because it's reconstructed, it's available to view. And then I've seen doctors go through it with the patient in real time and we'll tell them what's going on with each of their sinuses. And it's actually a really cool thing to see because then they start the treatment plan immediately. You can actually see the confidence start to build in the patient because they know that they're on that treatment plan now. And you have to also consider that, most of these patients, by the time they get to the ENT physician, they've already tried, the gamut of over-the-counter drugs. Perhaps they already saw their general practitioner because they have an HMO. Maybe they got a prescription for something. When they finally get that referral to the ENT specialist, if they don't have an in-office CT scanner, then they're referred back to the hospital. It's another appointment. Then at the hospital setting, a radiologist will review the scan. That's maybe a day or two later. Then another follow-up appointment back to the ENT, and then the treatment plan starts. But in the case of an in-office CT scanner, in some cases, in most cases, the patient actually starts their treatment plan immediately, which is really cool to see. As far as, as I mentioned before, there are some states that have more onerous regulations than others. Take North Carolina and South Carolina, for example. In North Carolina, anyone that's trained can push the button. It's very easy. And in South Carolina, they're very strict. Only physicians or radiologic technicians can even position the patient, let alone push the button. So it's just a totally different standard. But then even still in both of those cases, we recommend for the ENT physician to do their own reads. And occasionally some will outsource, and we have mechanisms for that because we provide an online PACS system, and a radiologist can take a look at scans and look at maybe a case that a physician wants a second opinion on. As Robert said, there are some cases where there's secondary, things going on. We suggest our ENT physicians to have let's call it a liability reducing, sentence in the report that specifically says the purpose of this scan is to scan your sinuses, and this interpretation is only looking at your sinuses. Now, when you scan, tip of the nose, back of the spheno, you're going to capture some of the brain, for example, but the ENT physician is not really looking at that. There's really not much to see in a cone beam CT scan, but there's in that case, the ENT isn't really responsible to actually do that read. If they have any questions about it or have any concerns, of course they could refer it on to someone else. But that's kind of the nice thing about the bone window imaging you're going to get with the CBCT scan. It's designed just for sinuses. It's going to tell you, if and where soft tissue exists in the space. In other words, if pathology is, in the sinuses. It's not really going to show you, if there's a sub-millimeter brain bleed. It's just not even going to show up. And we have that kind of disclaimer, suggested, verbiage at the top of the report to indicate to the patient exactly what this scan is for.
And let's stay with you for a moment, David. So is there specialized training for your ENT docs? I mean, I imagine for some of them, they haven't read an X-ray since medical school, but maybe you can talk a little bit about what training they may go through.
So actually, they're constantly going through training. At all of the, annual meetings that they go to, they're constantly looking at CT scans, and they're constantly getting that exposure, no pun intended, to in a CT image. And, a physician is going through showing them what to look for, and that's the interesting thing to me about ENT practices that don't have an in-office CT scanner. They're still looking at the images. They look at them all the time. And of course, they're going to review the report that came from the radiologist, but all of them are going to look at the actual CT scan themselves and determine for themselves what's exactly going on. In the case that we install an in-office scanner, not much of that workflow changes because they're still looking at the scan. In fact, their staff are still getting the prior authorization for that scan. That's actually happening whether they have the scanner in their office or not. The only difference is maybe the physician is pushing the button for 10 or 30 seconds. But that physician is definitely going to look at that scan. It's just whether or not their signature is going to be at the bottom of the report, which is actually optional. So I see that as some differences now between what Robert and my fellow David said.
Great. So let's skip to the next slide and talk about cone beam breast CT. And David Georges, the floor is yours.
Okay, thank you. I appreciate that. Cone beam breast CT was designed to address many of the well-documented limitations of conventional mammography. That's the business that we're in, is imaging the breast. And for the first time in breast imaging history, from the patient perspective, we have eliminated the requirement to compress the breast between the two compression plates, which of course is an exam no woman looks forward to. So we see this as a major advance. And radiologically, it delivers the first very true isotropic 3D data set for radiology interpretation of the breast from an X-ray emitting perspective. And this is a move away from the conventional two-dimensional images that are provided from a mammogram or a limited sweep angle linear tomogram of the breast. And the cone beam breast CT exam is very quick. It's only 7 seconds per breast, and the patient is lying prone on a table. So they're very comfortable. They literally can be on and off the table in about 2 minutes. And we do this at the same radiation dose as a conventional mammogram. That was an absolute must for our FDA PMA clearance. So the device also provides the ability to perform contrast enhanced imaging, which is very important for understanding any of the diseases that may be hidden by glandular tissue or overlapping structures, is what we typically refer to that as. And when contrast is used, cone beam breast CT is a direct alternative to a breast MRI, which today is considered the gold standard of breast imaging, is to get a breast MRI. But we are looking at sensitivity and cancer detection rate on par with a breast MRI. And we look at specificity slightly higher than breast MR. So we're very proud of the output of cone beam breast CT. And then we also perform biopsies on the device. There's a biopsy attachment that most radiologists and surgeons are very comfortable with. And that allows them to do an original scan, potentially use contrast, eliminate the need for an MRI, and to perform large core needle biopsies where we harvest samples and send them off to the pathologist for confirmation on whether the disease is present or not. So it's a pretty full-featured design, and it's one that literally can take a patient from having multiple exams, a screening mammogram, a diagnostic mammogram, an ultrasound, perhaps a biopsy, and then a confirmation by MRI. We literally can get this done in about 10 minutes by comparison to the existing standard of care. And it depends on the condition of the patient and how the images are going to be read and what the treatment plan might look like as we turn these images over to a surgical consultant or a oncologist. So from top to bottom, Mark, that's about the utilization of cone beam breast CT today. And if there's any questions, I'm here to answer them.
Let's just stay on this topic for a little bit longer, David. So I think there continues to be an issue with women who want to maybe don't get their mammogram on an annual basis as they should. Do you see a trend in the future where cone beam CT, because it's really quite different than a mammogram, would that make a difference in terms of the acceptance rate for women going forward?
Actually, we have seen a tremendous amount of response to both our social media and our active marketing campaigns for women that are calling our office daily and requesting information about where the breast imaging facility is that's using cone beam breast CT. I'd never thought it was going to be quite as prevalent as it was until I learned that there are 84 million women in the United States over the age of 40, according to the 2022 census. The MQSA has never reported more than 39 million screening mammograms in any 1 year. So that certainly indicates that there's a non-compliance rate, to your point, Mark. There's a non-compliance rate that is exceeding 54%. When surveys are done by other large strategic companies that manufacture mammographic equipment, overwhelmingly, the number one issue that women want to comment on is the fact that they do not want their breast compressed. It's uncomfortable, if not painful, depending on the woman and the composition of her breast, or whether she has an augmented breast or she's had previous surgery. They're just not willing to tolerate that discomfort, and that crowd is growing. It's not getting smaller. That crowd is growing as women learn more and more about the detection rate of mammography and the discomfort that they get from compression. Regardless of the advocacy groups, we're just not seeing an increase in compliance. We're actually seeing a decrease in compliance, and that's why we think that in our particular case, we're bringing this to the market at a perfect time. And is a perfect alternative for those ladies who just won't tolerate the compressional mammographic environment.
One final question before we move on, David. So as you speak to radiologists and in particular mammographers, what's been their take on this new technology?
Well, I have to say that most imagers, most radiologists are trained solely to find out what's wrong with something, which means typically when you introduce to them new technology, the first thing they want to do is to try to comment on, well, what could be wrong with this? And it's a natural reaction from most of the radiologists. But when they are able to see the data set that we're presenting, and they understand that they will never have to ask for another set of images to be done on that visit by the patient, they're beginning to understand that we are no longer manipulating the breast in a mammographic machine, which is a two-dimensional image. We are now manipulating the data set, and we're doing so in that isotropic format that allows them to see the breast from any angle at any slice thickness, from chest wall to nipple and from left to right or medial to lateral. So there is no limitation for them in understanding and interrogating the condition of that breast tissue. I think that most radiologists, if they give themselves about an hour and a half to 2 hours of working with our trainers, they come away feeling completely confident that that image is an image that delivers more tools to them than they're currently getting out of a mammogram. So I think that's the best way for me to answer that question, Mark.
Thank you. Okay, so let's talk about our next topic, which I think is going to be near and dear to many of the folks
Is
that
it
may
already?
be
I
on
jumped
this
in.
call in terms of reimbursement. And David Luick, let's start with you. What issues, if any, have you run into in terms of reimbursement for the ENT scans?
Well, by and large, most payers are paying, especially when you get accredited. So that's why accreditation is really standard now. When you get an in-office CT scanner, we take all of our customers through accreditation. Um, I'm actually not aware of any payers right now that aren't paying. That does not mean that, over the last 18 years or so that we haven't had some challenges with some individual payers in some regions throughout the US, but those challenges have by and large been overcome, actually with in large part help from Gary. So thank you again for that. But what it takes is just, some education. Maybe we get some experts together, um, some physicians, physicists, and we just have a conversation with these radiology benefit managers so they can understand what this technology is and what the benefit is to the patient. So again, by and large, our customers are getting reimbursed for their scans. I think on average, the reimbursement for CPT code 70486, which is your bread and butter CPT code for a sinus scan, it's probably around $135 from uh, Medicare. It's going to be a little bit more from the private payers, maybe 30, 40% more on average, which again is I tell my prospects anywhere from 15 to 20 scans per month is going to be your break-even point because most of the time these scanners are financed over maybe a 6 or 7 year period, and the monthly payment is, a couple $1,000 a month, and that's where your 20 scans comes from.
Before we leave you, David, what's the future look like for reimbursement? Up, down, no change?
I don't know. I guess I have to admit that reimbursement has been going down. It's been declining somewhat consistently over the last 15 years. I don't see that as a bad thing. I actually, the main return on investment from an in-office CT scanner is not going to be from your reimbursement from the scan. It's for most ear, nose, and throat physicians, it's going to be identifying all of the patients that are candidates for surgery. And as David pointed out, there's a compliance rate for patients that just don't want to go to the hospital and get a CT scan. They just don't want to do it, so they don't. And a lot of those patients would have been candidates for surgery, and those are, lost surgical cases that ENT physician would have otherwise gotten. Not to mention the relief that the patients would have had, much sooner. Um, so again, the real ROI is going to be for ENT physicians to capture the image at the point of care, identify the candidates for surgery, and get the treatment plan started immediately.
Excellent points, thank you. And Robert, so historically, dental has been more of a cash basis. You seeing any trends now where insurance companies are picking up some of that, or do you think it's going to maintain the status quo? That was to Robert. I'm sorry. Did I misspeak?
Sorry. Yeah. Thank you. I think it's interesting in terms of what we're seeing in the dental industry is cone beam CT is, well, I think we came from a place where, and it may be slightly different from ENT, where it wasn't standard of care to do any kind of 3D X-ray. So, your hospital axial CT wasn't something that was commonly used. So the direction we've come is a little bit from the opposite direction, where cone beam CT is starting to become more and more the standard of care. And I think it's being looked at differently from the insurance perspective as well. And not only imaging itself, but I think one of the biggest markets for cone beam CT imaging within dentistry is implant dentistry. And as that industry is becoming more and more mature and more accepted here as standard of care and maybe a little bit less elective, we are starting to see more reimbursement just all around. And so that's been really nice.
Great. And David Georges, so you're kind of new to the game, but anything that you've noticed as you've rolled things out?
Well, I've had many conversations with private payers in various regions, and I think they're beginning to get an understanding that there are some opportunities for cost avoidance if they would support breast CT, cone beam breast CT, both with and without contrast enhancement. So we're brand new to that environment where we are actually gaining an audience with some of the major payer groups in each state. And we're having these discussions routinely. It is helping to not only introduce the technology, but to give them a sense of how do they compare this with today's current standard of care between screening mammograms, screening mammograms, diagnostic mammograms, ultrasounds to confirm other findings, and potentially MRI and biopsy. So when we take a look across the existing landscape and workflow of a mammographic center, and then you insert breast CT, there seems to be reason for the insurance companies to at least, number one, take notice and listen, and then respond. We've got several that have taken breast CT into their policy committees to determine what they would do for negotiating rates with payers that have breast CTs. And we're literally just getting started, but I am very bullish on the response that we're getting. I think they see the need to not only improve compliance, but also to find a way to consolidate some of the imaging that goes on in a conventional breast imaging environment.
Great. Okay, so let's flip to the next slide and talk about accreditation, which is obviously near and dear to RadSite's heart. And maybe we start with David Luick here. You've been in the game for a while now, David. What benefits, if any, do you see becoming accredited?
Well, I like that you have reimbursement at the top because it's usually, the most important thing for a lot of our customers, which is fair. So I tell our customers, without accreditation, you may not get reimbursed. So there's many of the large payers, including Medicare, and the Blues and United Healthcare that require accreditation in order to get paid. So if you want to get paid, we get accredited. And once we get past that, that first thing that you've got there, then all of the rest are just no-brainers. It's sort of like they come along, for the ride, and they're equally as important. And some of these, arguably, more important. Like for example, promoting quality cannot be understated. The accreditation standards really get everyone on the same page in terms of what they should be doing as far as the interpretation reports go, or what the scanner specifications should be, or even how often they should be doing quality control, how often the physicist comes, just making sure everyone that purchases a CT scanner is just operating under this. I love that you have this seal of approval, because that's exactly what I would say. It helps the patient understand that this isn't just something that, this physician just bought and they're trying out this technology. It's definitely a tried and true method and is standard of care now. And patients can rest assured knowing that there is a rigorous standard that these practices, are applied to. So I think there's probably more than the reasons you have here, but I love that you have reimbursement at the top.
And David Georges, you just got your first site accredited, so congratulations. Tell
Thank
us a
you.
little bit about the accreditation process and, again, how meaningful it will be for you guys.
Well, I think to David Luick's point, I think that ultimately, as we introduce our technology to the major payer groups, that accreditation is going to absolutely have to correlate with their reimbursement strategies. So with our first cone beam breast CT accredited facility out of Dallas, they are now starting their conversations with the payer groups, including the MACs from Medicare, and they start the conversation out by saying, I'm FDA PMA cleared, I am AMA recognized with my CPT codes, and now I am accredited. And that conversation will then mature in a much better environment. And so we're very positive, and we're introducing the accreditation process to each and every one of our users currently. I think the RadSite will have quite a few of these customers joining in the accreditation process. And again, as David said, each of those other items just fall into line with managing a high quality cone beam breast CT environment that has been accredited. And we begin to understand all of the steps that are taken on an annual basis to guarantee that your image quality is proper, that your exposure to radiation is in a safe range, that you're requesting and gaining access to reimbursement. It's all a perfect series of events, in my opinion.
Thank you. And Robert, so for the dental market, accreditation is still a relatively new enterprise for your group. Any comments that you'd like to add in terms of the accreditation process?
I think Dave and David, you both making really good points. And when we look at how are we operating and how are we maintaining and using these machines effectively, that's really key and it's important for us. And also just, as an imaging facility, a specialty facility ourselves, there's understandably an economics of doing that properly. And, these machines, they are expensive. There is an upfront cost, there's maintenance costs. And that brings us to that reimbursement, Dave, that you were mentioning. And the reason it should be number one is because, it needs to be an economic decision, and we need to have the revenue to continue to support this as a program and not let it be a loss leader for our practices, for the industry. And so that's a really big piece of it, making sure that we are able to sustain it. And I think dentistry is a little bit different as well, in the sense that I think the primary markets that we're operating the CBCT in is still seen as maybe a little bit of an elective procedure, or at least in the eyes of insurance. But for a dental implant is going to be not the cheapest option for treatment. And so to some extent, for all of our clinicians, there is a patient presentation and sales aspect to it. And utilizing CBCT differentiates practices as a high technology, cutting edge practice that has very high levels of care. And what we're seeing is it's being used a lot for patient presentation and education. So the more we can get the patients to buy in and understand the treatment, it's really adding value to the entire process. And so having that accreditation is one more piece in that patient presentation and education that really sets us apart from that and adds value to the whole process that we're trying to do.
Great, thank you. Before we wrap up, Andy, are there any questions from the participants that we should get in front of our panel?
Hi, this is Gary. Yes, we have a couple really good questions. There have been a couple comments today about really how cone beam CT has changed and perhaps improved the standard of care in terms of the different diagnostic scenarios. And one question came in, it's a chicken or egg thing. What came first? Was it the technology that changed the standard of care, or is it the clinicians are expecting a little bit more fidelity in terms of their diagnostic imaging options? So how does each relate to each other?
Who wants to tackle that first?
I'll take a stab at it. I think, what's interesting is CT as a technology that's been around for a long time. Cone beam CT is relatively new, but, before in-office cone beam CT, patients had no other alternative than to go to the hospital and, get that scan and wait for the radiologist to review it, et cetera, et cetera. So I think that came first, and then this cone beam technology was eventually developed, and it's just a much better alternative to sending the patient, to the hospital, because they get their scan. It's much lower dose. It is high fidelity, and you start the treatment plan immediately.
Right. David
I
Georges?
think in dentistry.
Oh, Robert, go ahead.
Yeah.
Yeah. Thanks. Yeah. So, in dentistry, I think similar to what you're saying, David, is really, we were using some CT prior. And the beginning of cone beam CT, I think a lot of the focus was on we're making it more accessible because it's just easier to get. The dose is lower, so it just makes more sense, and the cost is lower. So it makes more sense to give us access to the technology and access to 3D imaging in general. But I think coming from the early days of when we first adopted cone beam CT to what we're seeing now, and as we're starting to develop the tools better and develop the education around how to utilize the imaging, what we're finding is cone beam CT is just hands down a better imaging modality. Because in dentistry, what we're trying to differentiate is, we're not looking at different nuances of density in a soft tissue. We're looking at, where do I see air in our sinuses? Where do I see soft tissue, and where do I see hard tissue? Right, so bone and teeth, soft tissue and air. Very easy for something like CT to differentiate between large differences in optical density. So we're getting arguably all of the information data that we need, and we also just get better resolution. So coming from medical CT with a very high resolution, maybe in an X and Y axis, for dentistry, if we're taking, let's say, 1 millimeter interval slices, for the purposes of dentistry, there's a lot that can hide in there. You might only be looking at a couple millimeters of vertical imaging. So the ability for us to get into the micron range of resolution in isotropically in all three axes, it's a huge value and arguably a better imaging tool. And I think we're definitely starting to see that now, or we have seen it, and and that's why it's becoming the standard of care.
David Georges, anything to add?
Sure. I think that in our particular environment, managing breast imaging, we were motivated to take a look at what could be the alternative to a two-dimensional mammogram, compressional mammogram. That was the driving force, and our hypothesis for development was, could we eliminate compression? Could we create an isotropic three-dimensional image? And can we do that in the same dose as a mammogram? So could it become an alternative to a mammogram over time? And certainly we have proved that hypothesis to be true, and we are commercializing at that level where we can certainly provide an alternative to the compressional mammogram. And using cone beam for the breast CT certainly was the only way that we could accomplish all of those goals, and to do so and deliver the additional tools that are not available to the radiologists today when they're taking a two-dimensional single access mammogram. So that's where we found that cone beam was going to be very important in our development cycles, and have since proven that to be quite true. So that's how the technology shaped up for us.
It looks like Mark may be frozen, our moderator. One quick question as we wrap up, and that is, what happens whether inside the field of view or outside the field of view you find an unexpected tumor or other kind of issue?
That's interesting. So a couple things there real quick. First, the field of view is collimated to a scout view. That's what you would acquire first. You basically take a single lateral X-ray and define what is going to be in the field of view for starters. And as I said, in the case of ear, nose, and throat use, you would collimate the field of view to just be the sinuses. And as you said, if there's something else that the physician doesn't recognize or wants a second opinion, we encourage them to send it out for a second opinion. And they send it out to another radiologist and get another read, perhaps someone that's more experienced in whatever it is that they're potentially looking at.
And I think, Gary, in the cone beam breast CT business, it would be incidental findings. Probably the most common would be linear arterial calcifications, which could be an indication of some form of cardiac malady. And radiologists are certainly communicating now that if I'm seeing these arterial calcifications, I need to report that not only in my report, but make sure that the referring physician understands that perhaps a visit to the cardiology office would be warranted. And there's other incidental findings, but that certainly is one that we see quite often when we're interrogating breast tissue.
Robert?
Yeah, for us, calcified carotid arteries is one of the most common incidental findings. Yeah, so on that line, yeah. And I would say, I mean, you guys touched on pretty much on everything, but when in doubt, refer it out. Yes.
I like that.
All right, Mark, I think that we're out of time, so I'll hand it back over to you.
Yeah, thank you. And I apologize, I may have lost connection there for a moment. I want to thank our participants today. Terrific opportunity to hear from the experts. Thank you all. We look forward to having you participate on our next webinar. Gentlemen, again, thank you for your time today. Really appreciate it.
Thank you.
Thanks for having us on.
RadSite would like to thank our moderator, Mark Casner, and our panelists, David Georges, Robert Chen, and David Luick. Just a reminder, today's webinar has been recorded and will be available through our website. If you enjoyed this presentation, be sure to visit our webinar page on RadSite's website or our YouTube channel for this webinar recording and past webinar recordings. Thank you for joining us today. We look forward to seeing you again at future webinars.